So we start the first session, and may I invite Dr. Tukaram Jamale from Mumbai, Dr. Saubik Sural from Kolkata, Dr. Valentin Lobo from KM Hospital, Pune, and Dr. Anil Ganju from...
Hello. Good afternoon. So as Dr. Umesh Khanna said, we are starting the academic conference, and after 3 years, it is great to see so many of our colleagues after a long time. And as Dr. Khanna said, that we learn a lot of theories, but practical tips at the bedside is probably very important. And the first topic, as already mentioned, the topic is challenges of drug dosing and monitoring in transplantation. Is a very important and practical topic. And to talk on that is Dr. K Venkataramanan. So I'll not take much of your time. Dr. Venkataramanan, please.
I think it's my privilege to be here. I should thank Umesh Khanna sir to given the opportunity to present this talk. And most of the audience here is most of the teachers. I think I'm always proud and privileged to present this topic in front of my teachers. Thank you. So regarding that, immunosuppression in kidney transplant, it challenges in drug dosing at the end of 1 year, 90 to 90. So TDM, therapeutic drug monitoring is advised for the drug. We have to monitor the drug because those drugs who are having narrow, most of the centers are not monitoring MPA, but still I think CMC, they are doing monitoring the MPA level to maintain the therapeutic window, and sirolimus and everolimus. So I think so it varies with the C0 or C2 if it is, and also tacrolimus, and most of the time at the initiation we are maintaining between 10 to 15 nanogram, but once after that we are maintaining that 5 to 10, but after the 6 months to 1 year we are maintaining around 5 to 6. So challenges in immunosuppression is because mainly variability in pharmacodynamics and also pharmacokinetics, because the drug before entering into the circulation, it has to absorb. So the pharmacokinetics is also influenced by motility of the intestine, whether if it is sluggishly going or it is very rapidly going, it also depends. It will lead to the modification and absorption, and also the glycoprotein. Enterocytes, there is a P glycoprotein. If the drug is a substrate for that glycoprotein, so when there is an inhibitor or an inducer or the efflux form, it may also lead the concentration of the drug inside the blood, then followed by metabolism, mainly by, I think most of the drugs are metabolized by cytochrome P450, except I think azothioprine. So most of the drug is influenced by whenever you are using the drug, which is the inducer or inhibitor of cytochrome P450, then you should be very careful. Then another is the enterohepatic circulation. That will also lead some drug to efflux again into the intestine and will late surge in the drugs. So this is a very important, we have to keep in the mind while we are prescribing the drug, especially when you are giving another drug which interferes with the P450 or glycoprotein. So what are the factors influencing pharmacokinetics of calcineurin inhibitors? Because I think calcineurin, most of our transplant protocol, inhibitor, previously it's cyclosporine, nowadays we are more commonly using TAC. So mainly absorption, distribution, and metabolism. So absorption, any drug which interact with the motility, any diarrhea or constipations or presence or absence of food, and especially, so we should be careful while we are prescribing the drug which interfere with that of motility. Another thing is the metabolism. So the metabolism, whenever you are prescribing drug, you should be careful with the metabolism, which has interfered with the P450. That's very common. Another thing, most of the time we forget is the grape juice fruit, so it interferes with that of metabolism. And genetic polymorphism is now very common. Whenever we are giving the drug, if you are not able to achieve the target, or if you are giving very small dose, if the patient is a high level drug, you should always think of genetic polymorphism in cytochrome P450. So we'll see that in the frequent slides. Subsequent slides. And hepatic impairment. Whenever the renal failure, you should be careful, because most of the MMF drug and CNIs both are metabolized by the liver. So whenever there is a liver failure, you should be very careful in the drug dosing. And others like timing of concentration and type of laboratory immunoassay, that is also very important, because most of the time I think we are using chemiluminescent microparticle immunoassay nowadays. Previously, even though that LSMS is a gold standard, but nowadays we are, most of the study centers, we are following with it. So the type of the laboratory immunoassay, the time of drug, the sample, and everything should be keep in mind. So the genetic and non-genetic variation, we know that genetic and also non-genetic metabolizing, the variation in drug metabolizing cytochrome P450 enzymes. So as you know, the cytochrome P450, There is a A4, A5, now even A6, A7 has also come into play. So the responsible for the metabolism of many immunosuppressants, as I told that, the pharmacokinetic variability now, previously they are divided into poor, intermediate, extensive, and ultra rapid. But now they are classified according to the genotype, that is a responder, non-responders. So the loss of functional mutation in cytochrome gene results in permanent poor metabolism. Not only the genetic or non-genetic factor also plays a very important role, so it leads to the even intra-patient variation. So the type of laboratory immunoassay, as I told that, the liquid chromatography tandem mass spectrometry, that is LSMS method was a gold standard. Even the previously also following that, even Lalpath also doing the most of the thing by LSMS method only. But the problem with this method has a low cross reactivity with the tacrolimus metabolite and even CNI metabolite. This metabolite exhibit higher specificity and sensitivity than other immunoassay. But the thing is cost. The cost is a little bit comparatively high, and also the level by LSMS is comparatively low when compared to that of CM. That is CMIA method. So you should be a little bit careful when you are giving both when you are comparing that. So the chemiluminescent microparticle immunoassay. Now I think we are most of the centers like Metropolis and SRL, they are doing by this method. So another advantage of this LSMS and by CMIA method is that is simultaneously you can measure all another immunosuppressants like that is a everolimus. So that is one of the advantage, and it is a gold standard analytic method for therapeutic drug monitoring. So these are the methods for even for the targets. So there are a lot of methods. I think previously in between that EMID method and even antibody conjugated magnetic immunoassay and everything was there. But finally, I think now even the recent studies, they had advised if you are able to go, you can go with LSMS method. But if it is not possible, better we can go for chemiluminescent microparticle immunoassay, CMIA method. So this is the study. You can see that is it's in 2010. The evaluation, they have shown that clearly in conclusion that tacrolimus CMIA assay is suitable for routine laboratory use and does not suffer from interference seen with compared to that ACMA method in some patients. So there won't be any interference of the tacrolide metabolite. That is the advantage of the CMA method as LSMS method. So coming to the cyclosporine, they are mainly two things, as you know, that non-modified and modified. I think most of the time, now we are using modified because it has a better bioavailability and compared to that of the non-modified. So there is not much difference between that modified and non-modified because it is also that is both metabolized by cytochrome P450 and also it is the substrate for glycoprotein P. So that inducers and inhibitors going to interfere with both the non-modified and modified. So cyclosporine, as you know that normally we starts at 4 to 10 milligram per kg body weight on the lower dose 4 milligram. Then we by therapeutic monitoring we will keep the dose. So between the narrow index. So coming to the C0, I think normally cyclosporine we advise for BD dose. So the 12 hours of concentration. So we are normally taking at 7 to 8 in the empty stomach. So with this approach, our C0 target of the following is within the first 1 to 3 months of transplantation, we can to maintain 200 to 300 nanogram per ml. After the subsequent month, if you're able to maintain 50 to 150 nanogram per ml for the subsequent months. This is for C0. But most of the people, they are telling that AU, area under curve correlates more with the C2 level. So I think most of the centers, they are doing C2 level. Even though the studies, they have shown that there is no difference in the adverse effect between C0 and C2 level. But the area under curve correlates more with the C2 level. So I think most of the centers, we are following C2 compared to the C0 level. So the thing is, we want to take the sample exactly 2 hours after taking the cyclosporine level. So our C2 targets varies from 800 to 1000 nanogram per ml in the first 1 to 3 months of transplantation, and followed by 400 to 600 milligram nanogram of ml for the subsequent months. So this is the thing. Although C2 levels appear to correlate more closely with area under curve 0 to 4 hours, but there is no difference have been observed in the 2 randomized control trial between the incidence of acute rejection, graft loss, even adverse effect, whether the patient would monitored either with that area under curve C or C2 level or C0 level. This is the I think studies, which is the supportive evidence. They have shown that even you can see there is no statistically significant thing. So yes, sir. Okay. So you can see there is no statistically difference. The importance of outcome is not that much statistically difference when you compare with that of the C2 level or C0 level. This is also the same thing. Even the p-value is not significant in all this thing when compared to that of C2 level and C0 level. So you can, even though the AU correlates with C2, but there is no adverse effect when you following that either C2 or C0 level. This is the importance of cyclosporin. But tacrolimus, the importance of tacrolimus, most of the thing I think center we are following the tacrolimus. So I think the problem happens with the tacrolimus. So the tacrolimus, there are the three formulation is there. One is the immediate release capsule formulation, and another is the extended release formulation, and now the tablet extended release also just arrived in the market. So it's available in the market. So I think most of the centers we are using that BD dose, that is immediate release capsule. But now that extended release also getting more popular because of the good bioavailability compared to that of immediate release. So the immediate release, normally we are taking BD dose. If it is a extended release, we are advising for OD dose. So the advantage of that extended release has a good bioavailability, and it is also good. The concentration is very good in the area under curve for extended release. So under the same thing, the CNS are metabolized by cytochrome 450. It is also a substrate of P-glycoprotein. So you should be careful, and whenever the patient is a liver cell failure, you should be careful because of most of the drugs are metabolized by P450, which is in the liver. So the tacrolimus typical dose, I think most of the centers we are following is 0.1 to 0.2 milligram per kg per day oral in 2 divided dose, and they starts at the lower end. So if it is kidney transplantation, the thing is based on that whether the patient is with immunosuppressant or not with immunosuppressant. So with induction or not induction. So if it is an induction, normally we give 0.1 milligram per kg body weight. But if you are treated with azathioprine, we start with 0.2 milligram. But in liver transplant, it's 0.1 to 0.15. But it is heart and lung, it is a little bit less level, 0.075. But if it is an infant, as you know, we normally starts at 2 milligram per kg body weight. So this is the thing, as I think Bansal sir is here, as the article from sir. So this is the proposed target level of tacrolimus concentration, whether with induction, without induction, with interleukin-2 receptor antibodies, with polyclonal antibodies, induction therapy with MMF and with mTOR. So most of the thing I think we are maintaining with initially 10 to 15. So once then at the year of 3 to 12 months, 3 to 10, but after the 12 months, we are maintaining at 5 to 7. But whenever there is any rise in creatinine or when you are suspecting toxicity, definitely you have to do TDA monitoring. So as I told that these are the different methods for that, even the tacrolimus, CLEA method and the CLEA method, CMA method, and but the last two, what we are doing is more commonly, that is chemiluminescent immunoassay, magnetic immunoassay, or mass spectroscopy method. So this is the practical points regarding the tacrolimus liver monitoring. As you know, the tacrolimus is the most common CNA we are using, and there is a large inter-individual and intra-individual variability with the TAC. So the previous things we are not using, though. So the best method of TAC level monitoring is, as I told, the LS-MS method, that is mass spectroscopy. But now the CMIA is more common because it is reasonable, accurate, and easy, can be used in most of the places. And coming to that polymorphism, genetic polymorphism, whenever you are not able to achieve the target because of the rapid metabolizer, or then you should go for the gene study, especially cytochrome P450 A5 allele. That is either whether the patient is having 10 or 30, you want to see, because one allele always the low concentration because the good metabolizer at the same dose when compared to that of 3/3 expression. So this is, I think it's very easy now. Even the Lalpath is doing that tacrolimus genotyping. If you ask for tacrolimus genotyping, they will give. So this is the one patient, the center there. This is the thing. Patient in this patient, it is 3 bar. That is allele. This is mainly P450 A5, because A5, when it is whether we want to see whether the allele is 1, 2, or 3. So if it is both the 1 and 1, it is definitely a rapid. So expressed as a rapid extensive metabolizer. So you want to give the double dose of normally what we are prescribed. So intermediate metabolizer, if it is 1, there is, if patient has 1 is 1 and another is 3. So if the allele is both 3, definitely they are the poor metabolizer. So you have to give only the half of the dose what normally you are prescribed. So if you have any doubt whether the patient is regarding that genotyping, or if you are thinking the patient you are giving very low dose, still the level is high. If you are giving very high dose, if the still is very level is low, and if you are not able to monitor the therapeutic drug monitoring, that is maintaining the window, then you have to go for gene typing. So this is the thing. So there is a genetic variation in expression of cytochrome P450. So mainly in A4, which is common, but A5 enzyme which metabolize TAC result in different level with same dose. Patient who expresses A5 that is 1-1 or A5-1-3 requires high dose to maintain the same level when compared to the non-expressors. So the non-expressors requires less dose and expressors require high dose. Otherwise, the expressor is otherwise known as extensive metabolizers. So this is a lot of inter-individual variabilities also there because of the non-genetic. So there are a lot of studies they have shown that is because of cytochrome A5 genotype markedly influence the pharmacokinetic of tacrolimus and sirolimus. All CNIs, because they are metabolized by cytochrome 450. So whenever you are not able to achieve, you have to go for genotype, the cytochrome P450 genotype. So this is also a study that therapeutic tacrolimus therapeutic drug monitoring stable kidney transplantation and individualization of cytochrome 3A5 genotype. So the genotype, even in the children, there is a study that has clearly shown that 1-1 is the rapid metabolizer and 3-3 is that. So this is the thing. The impact is that if the patient is at A5, 1-1, the dose is almost, the required dose is 0.15 compared to that of 0.075 when they are non-expressors. So this is the difference between the dose. Coming to that MMF, as we know, there is one is that plain MMF, another is that with the sodium, because of the sodium is common when the patient does have any GI side effect. But still, most of the centers, they are using MMF only because not a generic drug, MMFS is not maintaining the good level. So most of the centers, they are using MMF, but when there is any GI intolerance or any problem with the side effect, then they are using MMFS. So this is the main difference because of the less side effect with that of MMFS because of the sodium, because both should be taken in the empty stomach. And as you know that MMF is metabolized and it is mainly excreted by glucuronation and conjugate with the glucuronate, and it is excreted in the liver. And another thing, mainly it's not interfered with the P450. That is the main advantage of this when compared to the CNIs. So, and this metabolite can accumulate in the renal failure. That's why when the patient is having renal failure and they are after transplant, you should reduce the dose of MMF. But if the liver failure, you should be careful with the CNI dose. So this is the MMF comparison of the studies with the area under curve with the MMF fixed dose. Because I think most of the centers, they are believing that MMF fixed dose because we are not routinely monitoring MMF area under curve. As I told that, I think in CMC, they are routinely monitoring MMF area under curve because they are just changing the drug according to that. But I think most of the centers, we are using 2BD and then we will when the patient is a side effect, then we modify that. Or when a patient is a severe immunosuppressant, then we are decreasing the MMF. So this is the study. Even though in this study they have shown that you can see that whenever they are using the low, medium, and high, and they have changed into a 3 harm, and when compared that with a fixed dose, for example, 20 to 40 and 40 to 60 like that. So even that is a low area under curve and medium area under curve and high area under curve. Even they have shown that there is some significant rejection when compared to all this study compared to the fixed dose, but still it's not recommended that you should go under area under curve because there is not clear evidence that you have to go definitely because of the area under curve. That is, we want to monitor the MMF. So this is the thing normally what they are doing in CMC. So they are mainly monitoring the MPA. That is, only MPA can be monitored. The thing, they are taking sample of every 30 minutes. So almost, so normally they will put the cannula and they will take, because it's very difficult to pick the patient every 30 minutes. So they will put the cannula and they will collect the sample every 30 minutes from after taking the drug to up to 6 hours. So then they will put the drugs in the area under curve, and with the software, they will give the extrapolated MPA area under curve. So in this patient, it is 50.4 milligram per hour per liter. Or so the recommendation is you want to monitor the trough level around narrow index 3 to 5. Microgram per ml, or if it is going for area under curve, you want to maintain at least 30 to 60 based on the patient toxicity.
Can you summarize, Dr. Venkataramanan?
This mTOR inhibitor is almost that same thing. So drug interaction, as you know that you should be careful when you are prescribing that P450. And another important thing is whenever the drugs which inhibits the P450, we should be careful and we should give the less dose. When it is enzyme inducer, you should be very careful. You should give, especially that seizure drug medications like phenobarbital, which the carbamazepine of phenytoins, and acute kidney injury. Yes, whenever we are giving aminoglycoside or amphotericin B, cyclosporine NSAIDs, you should be careful. And severe hyperkalemia, whenever because both the TAC and CNI will lead to hyperkalemia, ACRB, spironolactone, and another MMF. And very important thing is whenever giving allopurinol with azothioprine, you should be very careful. So coming to the summary, the TDM of a systemic calcineurin inhibitor and mTOR inhibitor is essential because of narrow margin, as we know that because of adequate immunosuppression is needed. Otherwise, if it is more immunosuppression, it will lead to toxicity and infections. So tacrolimus is the most commonly used CNS, and therapeutic drug monitoring is mandatory to keep the desired level. There is a large intra-individual, even inter-individual variability in TAC levels. So the best method is LSCMS, but it's not available everywhere. So we better other thing, CMAI method is the other alternative which is available everywhere. And recording, if you're not able to control the TAC, go for TAC level with the genotyping. And 1 is the rapid metabolizer. You want to give the double the dose. What is 3 if you want to give half of the dose. So the appropriate tailoring immunosuppression medication is a great challenge and require careful and continuous attention, because unrecognized simple intervention can induce serious complication. As you know that it should be mastered because it's a double-edged sword with the immunosuppression. We should be careful. Thank you.
Thank you, Dr. Venkataraman, for a very difficult topic which you tried to cover up in 20 minutes. We have around 9 minutes for the chairpersons to initiate practical issues related to the same topic.
Before I throw it open to the audience, Dr. Venkataraman, could I ask you a couple of practical questions?
Yes.
One is, as you said, there is no difference in acute rejections whether you monitor C0 or C2 with cyclosporin, though the C2 correlates better with the AUC 0 to 4. Would it be correct to say that the C0 might better indicate toxicity because that's a trough level? That's one. And the second is with regard to tacrolimus, for those patients who are expressing the CYP3A4 polymorphism, is there any role to dose tacrolimus more frequently as used to be done with cyclosporin earlier? Or would it be, and is there a role to add agents like diltiazem today in 2023?
I think in the study they have definitely shown that when compared to the C0 and C2, definitely there is a rejection, acute rejection is more than the C2 level. They have shown that. But practical, in the study they have shown that the C2 correlates with that of area under curve 4. So that's why I think in our center we are doing C2, but most of the centers I don't know about that. Sir. And second question, sir.
Second was for those patients who have polymorphisms in cytochrome P3A4, is there any role to dose tacrolimus more frequently than twice a day? And what about adding agents like fluconazole and diltiazem?
I think in few centers, like I think in most of the GH, they are not able to maintain the drug. They are using diltiazem and fluconazole, ketoconazole to maintain the drug definitely. But even in this study, if you are suspecting there is any genotypic variation, better to do the genotype before going for that, and you want to start even at the 2 milligram per kg body weight in before transplant, starting the transplant itself. So it's advised.
Hello, Ramalingam from Coimbatore, and Venkataraman spent a lot of time on the gene polymorphism studies. We do not do it. We only go by the level and adjust the dose according to the level. We have not had difficulties, and we use induction. These things will be useful in discussions. And he also said that to reduce the dose of mycophenolate in renal failure, we do not do it. We go by the level of the WBC count. I will request everyone to comment on these two things.
One comment. We have been doing CYP3 1:1 gene polymorphism. And it was actually a thesis project, and we saw that 30% of our patients, they were high metabolizers. So this high metabolizers in India are quite common. We compared it with the studies from Hyderabad, SGPGA and 1 or 2 centers, and similar findings have been seen. So those people who are having lower levels, you should monitor and you should increase the dose. And one comment about mycophenolate, it should not be given along with PPIs because they reduce the levels of mycophenolate.
And this genetic polymorphism, do we do it before transplant or after transplant? Which way is better?
After transplant, if you have strong suspicion, then you can do it even before transplant also.
Is there any studies available saying that the
Sir, if you are, sir, the thing is, we are doing second transplant or
We don't do second transplant. Mainly we all do one transplant. Let us take up first transplant, not to be critical of anything.
in first transplant, not-
Practically, no, sorry. Practically, this genetic studies don't seem to be required unless we have, as somebody said, 30% of all of us are different in genetic handling. I don't think it is a very correct figure. What we have seen is only out of 30, 40 patients, one will have difficulty in achieving the level, or one will have difficulty in having very high levels. Subbarao?
I agree with him because we also did the study. We found 30% of them have got high metabolizers.
Have you got to sort of give very high doses in 30% of your patients? So practically, what is most important is the level we get rather than what is happening inside. It is true, it is good to do this. It makes us very clearly understand what's happening. But in the day-to-day practice, what is more important is if you get level with 0.11 milligram per kilogram given as 2 doses, or 0.12 milligram per kilogram given as 2 doses. And lots of times we adjust the dose according to the level. In most of our patients, we get the required levels.
Can I just change the question a little? By doing genetic study, would you reduce the frequency of monitoring tackle level? That's my concern. If you're not going to, yeah, if
think
you're
a lot
going
of
to
people are
monitor
against
frequently,
genetic
even
studies
in
right
spite
now.
of the genetic study, that would be it.
There was actually a paper which was
You people must give a verdict.
there was a paper which was published in the IJT.
I wanted to ask-
I'm sorry, sir. There was a paper published in IJT recently. Dr. Edwin Fernando's team did a study from Stanley. They monitored the genetics for CYP3A4, classified patients according to rapid, intermediate, and low, and dosed them to 0.2, 0.15, and 0.1. And they saw that by doing that, the number of times that they have to monitor is less, and they reach the target level faster at 1 month. So real-time, non-randomized prospective trial.
I think, and as genetic testing is becoming more freely available, you can do this polymorphism with an MLPA, which is not very costly compared to the cost of a transplant. So Dr. Venkataraman, would you say that then it should be perhaps routinely done before a transplant, seeing that the polymorphism is 30% of the population?
sir, it depends upon the center, sir. I think if the money is not an issue, definitely you can go. Sir. But
The cost
So
of
we have 2 minutes and 2
MLPA
boxers in the rings. One of them can immediately start. Yeah.
Yeah, I think, see, many times, practically when you get patients, they do monthly levels, and most of the time, because pharmaceutical companies provide them free, I'm not sure whether that's helpful. In fact, actually, you keep on, whenever you get levels, you keep to sort of change the immunosuppression. It may be all right for initial 6 months that you might need to monitor these levels more frequently, but after 6 months or so, you don't need to monitor it as frequently. And I think that sometimes monitoring it too frequently can create problems and it should be the trends rather than an absolute value, which is important on a long-term basis in this. No,
Yeah,
I think,
Manish,
see, we also did a genetic study. I didn't want, because the discussion has already been, we didn't find it useful at all. We didn't find it useful. We did it in about 80 patients, and we found that it didn't help us. We did it before the transplantation, trying to see it in chronic kidney
Thanks, sir.
disease
That
patients, and
answers
it
the
didn't help us. And about 20% of my experience is that 20% of patients with the usual dosages are underdosed and 20% are overdosed. So about 60 to 70% of patients are usually well dosed with the current recommendations of 0.1 milligram per kilogram body
I
weight.
think we are overdosed
Yes.
about the genetic studies.
I think probably.
I think we have just 30 seconds to go.
The practical difficulties sometimes 10, 12 years after the transplant, patients are doing clinically very well. Creatinine is normal. But if you do level, it's 2, 2.5. So do you need to fiddle around at that or just leave it like that? Or do you do a biopsy, increase the dose?
So I think,
Can I?
who is answering?
I think
No, I don't think we have time for questions. I just need time to thank Dr. Venkataraman and the chairpersons for doing a fabulous job. Well begun is half done. We've started the discussions on a much more war footing. Yeah, sure. Thank you. Sorry, we'll need to change the seat. Thank you so much, please.